afternoon. Welcome to our first of 4 live webinars we're going to be hosting this year for the Northern Colorado community dedicated to sharing knowledge and expertise when it comes to a healthy heart. Today, we're talking about how to navigate AFib and other heart rhythm disorders. Our goal, of course, is to empower you with the knowledge so you can live a healthy life. All right. Joining us live via Zoom today, we have Dr. Shane Rowan and Dr. Moe Lyons. Dr. Rowan, we're going to start with you. If you could just tell us a little bit more about your background and what you actually do at Banner Health, specifically.
Sure. Thanks, Chris. As he said, my name is Shane Rowan. I'm what we call a cardiac electrophysiologist. Essentially, I'm an electrician for the heart. I deal with a whole variety of heart rhythm disorders, from the atrial fibrillation that we're going to talk about today, to slow heartbeat issues, fast heartbeat issues. If it's a heartbeat, I deal with them. I did most of my training down at Vanderbilt in Tennessee, but I've been out here in Colorado for, 8.5 years now, working with Dr. Lyons and the rest of our great team here at Banner Health.
And so, Dr. Lyons, you're up. Give us a little bit of background.
Great. Thanks, Chris. So my name is Maurice Lyons, or everyone calls me Moe Lyons. I'm a cardiac and vascular surgeon. I've been here at Banner North Colorado Medical Center for about 17 years and do a whole myriad of different cardiac surgical procedures and vascular surgical procedures, as well as thoracic surgery. Cardiac related to the heart, vascular related to the blood vessels that come off of the heart, and then thoracic usually related to the lungs or the esophagus. And I've been here for quite a while. Again, share Shane's comments that we have a great team here. Really enjoy working together with the cardiologists. A few years back, Dr. Rowan was able to identify this type of convergent procedure, which is a combination of both surgery and EP cardiology, and we're able to successfully launch the program. It's been really a lot of fun to work more closely with Shane.
Great. Okay, so thank you, gentlemen, for those intros. So we're off and running. And here's how actually today's webinar is going to work. We're going to have Dr. Rowan and Dr. Lyons share some critical information to begin with. Then we're going to move into some previously submitted questions, and if we have time at the end, some live audience Q&A. Just a reminder, this is indeed a live event. So if you're having technical problems, we suggest logging off, logging back on, of course. That tends to fix everything. And if you'd like to submit a question, you can use the chat feature on your screen. Again, if time permits, I'm going to see it come up right over to my right, and we'll hopefully get to your questions. And throughout the webinar, we're going to have a number on the screen that you can call if you need to make an appointment. All right, Dr. Rowan, once again, you're leading off. Can you define AFib for us? What exactly is it?
Yeah, so AFib, atrial fibrillation, AF, you'll hear us call it a lot of different things. It is when the top part of your heart, what we call the atria, it is when the electrical system up there goes haywire. Normally, when your heartbeat is going as it should, you have a natural pacemaker up there that everybody's born with, and it sends out little electrical signals that tell your heart when it's time to beat. When atrial fibrillation happens, that nice orderly signal is disrupted, and it's like there's electrical static up in the top of your heart. That has a lot of consequences. It causes your heartbeat to become irregular. It skips and jumps around. It can cause your heartbeat to go fast, and it will also, unfortunately, increase a person's risk of stroke.
Dr. Lyons, what are the age groups we're talking about? Can anyone get this?
Anyone can get this. Tends to be seen more commonly in older patients. So as the heart undergoes structural changes as we get older, it tends to stretch the atria, that top part of the heart that Dr. Rowan's talking about. And that increased pressure, increased stretch can lead to this abnormal electrical impulse that kind of messes with the timing of the heart. You know, any of the folks out there who've ever worked on a car, when the timing gets off on the car, back when we used to work on our own cars, the engine never ran quite correctly, and this is an example of it. When the timing gets thrown off, the heart does not work nearly as efficiently as it does when it's in sinus rhythm.
Dr. Lyons, let me stay with you. How common is this?
So I don't know, Shane. What is the incidence of this?
All right, then overall? We'll go to Dr. Rowe. Yeah.
I'm more of a cutter. He's more of a thinker.
There you go. Anybody jump in. How common is it? And then let's go to treatment options.
It's extremely common. It is the single most common heart rhythm disorder that we see. By age 80, something like 1 in 10 people will have developed it. So it's extremely common.
Treatment options, what are we talking about?
I'll mention a couple. There are a lot of treatment options for atrial fibrillation. That's the good part about it. Treatments have to be directed at two different things with atrial fibrillation. On the one hand, there's how atrial fibrillation makes you feel, the symptoms you develop from it. And we have a bunch of different treatments for that, which maybe I'll let Mo go into some of. Sure. But there's also this issue of the risk of stroke on the other hand. We also have to have treatments addressing that. And so for both of these things, how you feel, the symptoms, and for the risk of stroke, we have medications, procedures, surgeries, things like that we can do. Mo does the convergent procedure for very advanced cases of AFib. Maybe chat about that.
Sure. So as I mentioned earlier, really did very little electrophysiology work over my first 15 years of practice. And then a few years ago, Shane identified this hybrid procedure. It's hybrid because there's both an open surgical part and then there's also the catheter-based part. Dr. Rowan's an excellent catheter-based electrophysiologist. And so with the small catheter, he can go in from your groin and identify sources inside the heart where that irregular heart electricity impulse comes from, and he can burn them. The problem is, as AFib progresses, more and more of the atrial tissue, A, the atrium becomes larger, and B, more and more foci, more and more spots become available to send this aberrant signal to the atrium, where the atrium, instead of beating at normally 80 beats per minute, the atrium beats at 300 beats per minute. It goes into this short circuit where it starts contracting. The way I've heard it described, and certainly the way it looks clinically when I'm looking at a heart, is instead of having the heart contract like this, it just wiggles. It doesn't really do anything. It just kind of tremors. And so with this convergent procedure, we use a much larger catheter that's probably about as big as the end of your pinky. And it's able to control a larger area of left atrium, which is where these foci tend to come from. And I'm able to apply energy, radio frequency energy, to that part of the heart, which will then ablate that area so that it's electrically silent. And that by making that electrically silent, I can take care of a good portion of it, but I can't get around to the front of the pulmonary veins from under the heart. And so it's actually a hybrid procedure because I do that large area on the left atrial free wall, and then there's a little touch-up area that Dr. Rowan can do catheter-based at about 6 weeks. And then he could also go by and check my work and see how electrically silent the heart is. Typically takes about 3 hours to do the operation, 2 to 3 hours, and then typically you spend a day or two in the hospital. So as Dr. Rowan mentioned, there's two distinct problems with atrial fibrillation. The first problem is this funny heart rhythm where the atrium's not beating in synchrony with the ventricle, and then it kind of just wiggles and jiggles and doesn't actually move a lot of blood into the ventricle. The second problem is the predisposition to clots. So as the atrium contracts like this, blood is ejected from the heart and it moves. But if it's just doing this, you can imagine blood would be kind of static. And when blood's static, it does what blood's supposed to do, it clots. And there's one particular part of the left atrium called the left atrial appendage. And that area, if it's not contracting and squeezing, blood pools in this area and it forms clots, and that's the risk of stroke. So AFib causes problems with the cardiac efficiency, and it also predisposes you to stroke because of that little outpouching called the left atrial appendage. So as a combination with the convergent procedure, in addition to dealing with trying to stop the electrical impulses that are abnormal, we can actually open up through a separate incision, through 3 small incisions on the left side of your chest, the sac around your heart, and put a device called an AtriClip across the base of the left atrial appendage. So where that little appendage is, I slide a little clip and I pinch that off so that that part of the heart is no longer available or in the blood pool so that clots can't form and cause the risk for stroke. So it tackles 2 problems, both the AFib and this funny electrical thing and the predisposition to clot. And then Dr. Rowan goes back and touches up those areas that I can't get to. And thankfully, we've had great success with it here locally. I've been around long enough that I remain fairly dubious about new technologies. I'm kind of a Surgisaurus, unfortunately, as I get older. But when I looked at this technology and went out and did the training necessary to start the program here, I've been very, very impressed. And most importantly, all we care about as providers is how do our patients feel? And the patients come back and they feel really, really good. The AFib's well controlled. And I know a lot of people here locally in the Greeley area. I'll see them at the grocery store, and they're just really happy that they had this done because they feel like they're getting their cardiac issues resolved and they feel like they're getting their life back under control.
Yeah, I was going to ask you, doctor, about recovery from a procedure such as this.
So the first incision is made right over that little sticky out thing that we have at the end of our sternum called the xiphoid. It's probably about 2 inches long. I actually tend to remove that little piece of cartilage. You don't need it. And then that allows me access to the sac around the heart, and I can get this in there. That takes about 2 hours or so. And then as I mentioned, we go in through the left chest and do the clip. You're in the hospital for 2 days. Pain's minimal because we don't make big incisions. People take pain pills for a day or two typically. You have a couple of tubes that drain. One drains your left chest. One drains this area under your sternum. And those tubes usually come out post-op day 1 or post-op day 2. And then you're home. And typically people have minimal complaints with regards to pain, or they feel a whole lot better. The important thing, it's funny, people expect this to work instantly, and because we're applying this energy, it takes about 2 months for those energy burns to mature. So if you come out in sinus rhythm, that's great. But if you don't, sometimes it takes those burns a little longer to mature. It may take a month or two to have those burns fully mature to really deal with that electrical issue. And that's why it's great that Dr. Rowan goes back in about 6 weeks, because he can check that whole area in the left atrium, make sure that it's electrically silent, and then he can do the part of the procedure that he needs to do. But just because it doesn't work initially like day 1 doesn't mean that over time those energy burns won't mature, and we'll get better control of what we call the atrial fibrillation substrate.
Got it. And thanks, doctor, for laying that out for us. And since you did, and then you mentioned about maybe 6 weeks later, Dr. Rowan will come in with his type of procedure. And Dr. Rowan, could you just enlighten us a little bit about what that is?
Sure. I think it's important to remember that the vast majority of people that we see with atrial fibrillation don't fortunately require most skills. We have other procedures and things we can do for them that don't require going to the operating room, although it is a very valuable adjunct for those people who need it. A more typical, what we call endocardial, meaning inside the heart ablation procedure, involves someone coming into the hospital the day of the procedure. We put in IVs or tubes into these large veins that you have in your groin. And we use those tubes to pass wires up to the heart that let us see the heart's electrical signals. We then have special wires where we can zap, if you will, these irritable spots that tend to cause the atrial fibrillation. A procedure like that is done under anesthesia and typically takes about 2 hours, with many people going home the same day from something like that.
Got it. Thanks for pointing that out. Yeah. Hopefully it's not as to an extreme where you have to go see somebody by Dr. Lyons. Thank you, Dr. Rowan. Okay, let's talk a little bit, actually quickly, about, are there any common myths that you guys hear maybe surrounding AFib that you want to clear up for our audience?
Probably the most common one that I deal with is people think that caffeine or coffee is causing their atrial fibrillation. We like to blame coffee for a lot of things, or caffeine for a lot of things, and certainly probably having 10 Monster energy drinks a day is not good for you in general. But in terms of just moderate coffee consumption, that has not been associated with atrial fibrillation. So I always encourage my people to go out and enjoy their cup of coffee in the morning.
Good. Okay, great. I'm sure you have to answer that question over and over again, both of you.
Even with other physicians.
Definitely. You know what? We're going to jump around a little bit here during this webinar because we have some submitted questions. I'm going to get to those, but folks are watching. They're adding some questions on the fly, so I want to get to those so we don't run out of time. Here's the first one from our live audience, and both doctors jump in. If you have AFib, can you exercise, and do you have to stay under a certain heart rate?
Yeah, you can definitely exercise. When a person says when you have atrial fibrillation, there's a little more that goes into that, because there are different types of atrial fibrillation. Many people, when they first have AFib, have what we call paroxysmal atrial fibrillation, meaning they go in and out of atrial fibrillation. So certainly when they're not in atrial fibrillation, exercise is perfectly fine. If people are in atrial fibrillation, Either they just happen to be in it that day, or they progress to the point where they tend to stay in atrial fibrillation, what we call persistent atrial fibrillation. Then we do have to pay attention to heart rates. The good thing about heart rates and exercise, though, is if your heart rate gets too high, your body will stop you exercising. You really do not feel good if you exceed the heart rate you're supposed to be going at for exercise, and so your body will tend to slow you down. It's more an issue for us in treating atrial fibrillation that we have to slow down people's heart rates enough to allow them to go out and do the exercise they want to do. I always tell people that atrial fibrillation should not limit how you live your life. We should treat the atrial fibrillation so that you can go out there and do what you want to do.
Thank you, Dr. Owen. Dr. Lyons, you want to add anything?
What I will add is that I've got this idle timer expired thing showed on my screen, so I don't know if you guys can see me okay, but I've got this big blue stripe across the way here.
I think we got you fine, yeah.
Okay, good. I just don't know how to get rid of it. So I agree with Dr. Rowan. I mean, obviously, exercise is really important for people in terms of maintaining their overall health and body weight, and also to have, it helps you have, I think, a better outlook on things. But if your heart rate gets to a certain level, then obviously you're not going to be able to do things. And a lot of times people with atrial fibrillation frequently are on anticoagulation. Shane, about how many people who have AFib, the Chad Basque thing, how many people do you think of your patients are on anticoagulation chronically? Half, less?
Anticoagulation or blood thinners, much more than half. I would say 80-90%.
89%. Okay, so if you're exercising and you're doing CrossFit, you probably don't want to drop a 25-pound weight on your foot because you'll bleed. But I think that exercise, for me anyway, exercise is an important part of my day just because it helps me kind of keep my mind clear. So
got it.
If I get AFib, I'll probably still exercise.
Better.
And like Dr. Owen said, your body's going to tell you with that heart rate.
Yep.
So, okay, another live question before we get to some submitted questions. Are atrial flutters a form of AFib? Because those are very common. Something, just a little irregular, quick flutter. Is that something, is that a symptom, a sign of something, gentlemen?
You want to go ahead, Mo?
Well, sure. I mean, atrial flutter is a different type of heart rhythm. Palpitations are super, super common. And so people can get palpitations where they feel their heart skip a beat, and that can be related to PAs, pulmonary premature atrial contractions or ventricular contractions. Dime a dozen, lots of people have them, and those can be made worse by caffeine. But a flutter is a very specific type of atrial rhythm abnormality, and Dr. Rowan treats that with similar approaches, catheter-based therapies and medicines and things of this nature. It's less common than AFib for sure, and but it tends to have it tends to be a very definable clinical entity. A lot of people confuse or conflate a flutter with palpitations. Palpitations can be caused by any number of different type of funny heart rhythms.
Yeah, I think that's an important point, Mo. People come in and tell me they have a flutter, and what they usually mean is they feel their heartbeat doing a little flip and then it goes away. When we say someone has atrial flutter, we mean a very specific rhythm diagnosis related to a particular short circuit in the heart. And so we're using different terms there that we have to be careful about.
Okay, good. Thanks for clearing that up. Another live question. We have a great live audience, so we're getting lots of questions on the fly, so let me get to them. Do you still have to take medication for AFib and blood thinning after a procedure is complete? Doctors?
Depends on the procedure. For Mo's procedure, go ahead, Mo.
So most people are going to be on some type of anti-rhythm agent, typically a beta blocker, most commonly, which everyone kind of uses very frequently. Some of the other types of medicines, like, for example, amiodarone, which is used to treat atrial fibrillation, tends to have a little different toxicity profile, can be tougher on the lungs, can be tough on the thyroid. And so we try and get people off of those types of anti-rhythm medicines that are more prone to cause problems from chronic use. I think that's a fair statement, Shane. Would you agree with that? Beta blockers are, they're a dime a dozen. Everyone's on them, and they tend to have a pretty good, they're tolerated pretty well overall. The anticoagulation question is a great question. So when we first started doing these convergent procedures, we only worried about the rhythm aspect of things, and we didn't deal with the left atrial appendage. And then about a year ago, we started doing these AtriClips on the left atrial appendage. So that blocks off that little area, that little outpouching of the left atrium where clots tend to form. So we put that on, and I actually do that in the operating room with an echo probe at the time. So I'm looking real time at the heart, and I'm applying this clip to make sure I completely occlude it. But before we stop anticoagulation, typically at about 6 weeks or 3 months, we repeat that echo to make sure that that closure is still good, because the downside of a stroke is so great that we want to make absolutely sure that where I put that clip, there's no blood going into that area before we stop the anticoagulation to really minimize the chance for stroke. Dr. Rowan, as an independent procedure, does something called a Watchman device. And that's a little thing that's treated endoluminally, or from inside the heart. And the same basic protocol there. He tries to block that area off so that blood can't go into that area, and that helps us get patients off of chronic anticoagulation.
Yeah. For my type of procedures, when I do a regular ablation, not involving Moe, patients do not come off their blood thinners afterwards. I always tell people, if you needed a blood thinner before I do this procedure to you, you're going to need the blood thinner after I do the procedure to you. But there are other medicines, we call them antiarrhythmics, medicines that affect the heart's electrical system, that are meant to keep the atrial fibrillation away. And depending on the person and an individual situation, those may or may not be stopped after an ablation procedure.
Here we are during the pandemic, gentlemen, and here's a question. You knew this was going to come in. What happens if I have AFib and then get COVID? Is there anything specific that you can get across to the audience?
Your AFib will likely be worse while you have COVID, and for some time afterwards.
Okay, so just deal with that, and hopefully that won't happen. All right, another live question coming in. Who is the best candidate? I guess a general question. Who's the best candidate for a procedure? Any of the procedures for AFib?
So I tend to see the people in the office and send them out to Moe, or keep them myself, depending on what I think is appropriate for people. And so for the procedures we do for atrial fibrillation, the best candidate for any ablation procedure is someone who is still in early atrial fibrillation, meaning paroxysmal atrial fibrillation. If your heart is still going in and out of atrial fibrillation spontaneously, then we have our best chance of helping you, of making the atrial fibrillation go away. Along with that, the healthier you are otherwise, the younger you are, all those things tend to increase our chances of success. That being said, we don't live in a perfect world, and many of the people we see already have advanced atrial fibrillation and other things wrong with them. If the atrial fibrillation has been going on for months or years uninterrupted, then that's the time where Moe's procedure really shines. Those are people where I will not achieve success, but with Moe's help there, we can get these people back in rhythm.
And there's limitations. I agree with everything you said, 100%, Shane. There are probably more than half of the patients that I do the convergent procedure on have already had a catheter-based procedure at some point. So they've already had an attempt at ablation catheter-based, and so we tend to use convergent. But just as I mentioned earlier, as the heart, the atrium in particular, grows and stretches, it becomes more difficult. So I do open surgery as well, and I'll replace mitral valves and all sorts of stuff like that. And I'll oftentimes have those people, they'll have AFib before they need their open heart surgery. And I approach atrial fibrillation different if your chest is open. I have different tools that I can use to complete an ablation. But there are certain times where I know an ablation won't work. If someone's got a 7-centimeter left atrium, that atrium's so big and it's so distended that I can, do all sorts of crazy procedures. And I know that atrium is beyond the point where it's ever going to achieve sinus rhythm again. It's never going to contract normally because it's so big and so dilated. So there are some people, as Shane mentioned, the ideal person, somebody who hasn't had those significant structural changes yet. But there are some people, unfortunately, that come very late and they have these problems. And at that point, we fix the valves the best we can. But to take someone with a 7-centimeter left atrium, you're not going to get that atrium to work properly ever again.
Yeah, there are some people who end up living in atrial fibrillation all of the time.
Yep.
And with proper medications or sometimes even pacemakers, we can help those people generally feel pretty good.
Okay, more questions coming in, doctors. Let's see. Is there a greater chance, this is dealing with complications, a complication question. Is there a greater chance of complications if a patient has asymptomatic AFib or bradycardia?
I'm not sure what is meant by complications in this setting. I will say that whether you feel atrial fibrillation or not, your risk of having a stroke, which is the most dreaded complication of atrial fibrillation, is the same. Whether you feel it or not, that risk is still there.
Let me follow up because there's another question that, obviously, if you're feeling some sort of symptoms, this question is very specific. My husband is showing symptoms, refuses to see a doctor. What happens if he continues to ignore it?
His wife will kill him. That's what'll happen.
Yes, yeah, that's exactly right. Do you know, I'll tell you, one thing that I think is pretty interesting, in those people who can afford it, this little, $200 gizmo that you wear around your wrist, connects to my iPhone, and it will actually tell me when my heart rate is fast, and there's actually a package apparently that can pick up atrial fibrillation. Just as Dr. Rowan mentioned, I mean, the problem for your husband is that if he waits and he has a stroke, there's nothing we can do. People have a stroke and they lose part of their brain. There's no way to fix that, not in 2021. So what I would encourage your husband to do is to get seen, because he's not going to want to live with a stroke, and you're not going to want to take care of him after a stroke. And it is in large measure preventable. So if he's feeling these symptoms and if he's concerned that he has these problems, go and get seen. And if he can't go to a doctor or won't go to a doctor, consider getting one of these kind of monitoring devices. I saw one, I think it's called the Cardone or something like that. Is that what it's called?
Cardian.
Something like Cardian. And then it's $100. I think it's $99 or something. I see it on TV, and you put your 2 finger pads on it, and it'll give you a real-time EKG. Not a perfect EKG, but give you a sense of whether you're in sinus or not. So, if he's really being resistant, let him know that the risks are great and that he may end up not moving half of his body or have no ability to speak, which are 2 of the more common sequelae of a stroke. And so he'll have the rest of his life to regret the decision of not being seen if that occurs. And then if you still can't move the ball there, then see if you can go out and get one of these $99 things from Walgreens or Walmart and hook it up to your smartphone, and you'll be able to see real time what his heart rhythm's doing. And maybe that would convince him, if he says, well, yeah, I do have AFib, to go in and get seen by his provider.
Mm-hmm.
Yeah, and I would say the initial visit doesn't have to be with us if he doesn't want to come see a cardiologist or something. If there's any physician or healthcare provider in his life that he trusts, they can order a heart monitor, which is usually the first step in diagnosing atrial fibrillation.
And that heart monitor, you wear it for like 12 or 24 hours, is that correct?
There are a whole variety of them out there. There are some that are as short as a day and some that last up to a month.
Sure.
For people who have very infrequent symptoms, this comes up all the time. Somebody will say, well, I wore your heart monitor for a month and I felt nothing because this only happens to me once every 4 or 5 months. There's actually a small implantable heart monitor that's slightly bigger than my paperclip that goes under the skin and watches a person's heartbeat for up to 4 years at a time. So there are a variety.
Variety of things. Okay, another question. Can AFib or an ablation cause you to have a greater incidence of other types of arrhythmias?
Great question. Tough question to answer, frankly. Yeah, there are some things that we can do when we're doing an ablation, and we can cause something called atypical flutter. An atypical flutter, if I create that doing my convergent procedure, that makes Dr. Rowan's day really hard because it's really hard to treat. So why is that important? Well, it's important that you understand the anatomy. It's important that you understand where you can apply these energy applications. If you apply that energy application over the coronary sinus, which is a big vein that drains the back of your heart, you can actually promote atypical a flutter, and that's difficult to treat both medically and catheter-based. So, yeah, there are some things that can get worse. Probably the most common thing I've seen from my open AFib cases, my mitral valve replacements, my aortic valve replacements, and coronary work, is bradycardia requiring a pacemaker. But I promise you, you are far better off with a pacemaker and a controlled heart rhythm than you are with atrial fibrillation, because it restores that timing component that allows the atrium to contract and allows that ventricle to get that final bit of what we call preloading, where it gets that last little bit of blood from the top of the heart, and that increases the cardiac efficiency on the order of about 20%. And so if you have if I have a bradyarrhythmia after I do a maze procedure or some type of energy application, I don't worry about that. As long as I control the AFib, even if you need a pacemaker, you're far better off with a pacemaker and a controlled heart rhythm than you are with a very irregular heart rhythm, which doesn't allow the heart to adequately load. Would you agree with that, Shane?
I would, and I would say the likelihood of developing one of these problem heartbeats after an ablation, again, depends on how early people come to us. If someone comes in very early in their AFib and I can go in just on the inside of the heart, I use this balloon to freeze around these problem areas. The incidence of these problem, what we call atypical flutters, is probably 1% to 2%, so they're very uncommon. The more work we have to do in the heart, the more other areas we have to address, the more likely those become, unfortunately.
Here's a great question. Can you, both doctors, talk a little bit about the interaction of heart rhythm disorders and sleep apnea?
Shane, I'll let you take that one. Certainly there's a strong correlation there.
There's a very strong correlation. Some people estimate that 80% of people with atrial fibrillation have sleep apnea, whether they know it or not. It's an important thing to address because if you have sleep apnea, then treating that sleep apnea will make your atrial fibrillation a whole lot easier to handle. It makes anything we do more successful. There was an interesting study a few years ago where people got ablations to deal with their atrial fibrillation or they didn't. And then of those people who got ablations, some of them got treated for sleep apnea and some didn't. The ones who didn't treat their sleep apnea, it was like they never got an ablation. They did just as badly as the people who never got an ablation in the first place. And so treating sleep apnea in order to help control the atrial fibrillation is important. And I should mention that sleep apnea also does a whole lot of other bad stuff to you. It can increase your risk of diabetes, high blood pressure. Oh, and it'll make you feel really tired too if you have a severe case. And so you'll have a lot more energy if you treat it.
Speaking of feeling tired, another live question just in. A viewer has a persistent AFib, works out regularly. In the last few months, they have had pronounced tiredness, a lot of fatigue. They fall asleep during the day for hours. Is this connected to AFib? I would imagine so, but how deeply?
It could be connected to a number of things. I would be suspicious about sleep apnea, hearing the bit about falling asleep during the day. One of the classic symptoms of sleep apnea is what they call daytime somnolence. Basically, you sleep for 10 hours at night and you're still tired when you wake up because your sleep is of such poor quality. Then you have a tendency to fall asleep driving, reading, watching TV, stuff like that. Certainly a change in symptoms like that, for going from able to exercise to being very tired, is concerning. I would say that person needs to be checked out.
Okay.
Whole host of things that come to mind, thyroid issues, sleep apnea issues. There's all sorts of things that can cause that to occur. So a thorough exam by his primary care doctor from head to toe with labs would probably be a good place to start.
Yep.
What about this question? And you guys have touched on this, but overall, I think this is imperative. What lifestyle changes can someone make to help control this condition?
Alcohol consumption, I know, is one thing that if you drink a lot of alcohol, it can kind of keep you in AFib. Caffeine, I actually believed that myth until Shane demystified it. But yeah, I know alcohol consumption can be a promoter of atrial fibrillation, and certainly untreated OSA or obstructive sleep apnea that Shane was talking about, or not being compliant with wearing your therapy at night would be another driver.
Yeah. The best lifestyle things you can do are things to prevent AFib from happening in the first place. Maintaining a normal body weight, going out there and getting some exercise, keeping your blood pressure under control if you have high blood pressure. Those are all things you can do to help you prevent atrial fibrillation. In terms of controlling it when it happens, Mo's absolutely right. Alcohol consumption is probably the biggest trigger and perpetuator of atrial fibrillation that people can control.
And Dr. Rowan, I know you sort of touched on this a few moments ago, but overall, do most people who have AFib, do most people need some sort of surgery, whether it's that really complicated, extensive surgery that Dr. Lyons does, or just overall surgery, or can it be stopped before we get to that point?
I would say the minority of people get a procedure. And this is people who come to me who's a specialist. And so there are many people with atrial fibrillation whom I never see. They're managed by their primary care physicians or regular cardiologists. So no, I would say many people with atrial fibrillation do not need a procedure. Now, interestingly, I think the needle is moving a little bit on that. There were 2 studies that came out in the last month saying that if you jumped on AFib early and did an ablation procedure while you were still going in and out, you tended to do better over the long term. So we may be changing our tune on that in the future. But as of right now, I would say probably under 20% of people with atrial fibrillation end up getting some kind of procedure.
What about other specialists? And Dr. Rowan, I think you mentioned this as well. Maybe in the early stages, someone feels like it may be more than just a flutter. It may be the beginning stages of AFib. They go to their primary care. What would happen before they would come to see someone like yourself? Or would there be someone, or would they just come to someone like yourself?
It happens both ways. I certainly get people who self-refer because of symptoms they're having, and I get a bunch of people who are referred by their primary care doctors. If you come in to me or your primary care physician complaining of something is going on with my heartbeat, or I think my heartbeat is funny, chances are that you'll get an EKG. That's where they put the stickers on you and they run a quick 10-second strip that shows what the heart rhythm is doing. If people are in atrial fibrillation at the time, that may be it. That may be sufficient for the diagnosis. In many people, like I said, they go in and out, and so some kind of heart monitor is often ordered at that point in time. And then depending on how that goes, additional testing such as an ultrasound of the heart and some basic blood work to check the thyroid, like Dr. Lyons mentioned, stuff like that is often done in an initial encounter as well.
Are there any definitive conditions that can be defined, if you will, as a precursor to AFib?
Certain valvular disease is very commonly associated with AFib. So mitral regurgitation classically, or mitral stenosis for that matter, is a valve that exists between the atrium, the top chamber of the heart, and the ventricle on the left side called the mitral valve. And if that valve leaks a lot, or if that valve is really, really sticky, something that we see in patients who've had a history of rheumatic heart disease, then blood has a hard time going from the atrium to the ventricle mechanically, or once it gets to the ventricle, it leaks back into the atrium. That tends to stretch the atrium, and as we mentioned, stretching or dilating an atrium is a good way to get that atrium to lose its ability to conduct normally, and it starts getting into this reentry rhythm, we call it, where it starts to kind of fibrillate, typically at a very high rate. So that if you have mitral regurgitation or mitral stenosis, it's pretty common if you let that go long enough that you will develop atrial fibrillation as that atrium stretches.
Yeah, I don't know about a true precursor condition, but there are a whole lot of things that increase risk for it. The mitral valve disease Moe mentions, almost anything else that's wrong with your heart. If you have heart attacks, if you have heart failure, high blood pressure, all those increase your risk. The atrial flutter that we mentioned earlier is kind of an interesting one. It's a specific short circuit that's separate from the atrial fibrillation. But it turns out that if you have atrial flutter, you end up with about a 50-50 chance of going on to develop atrial fibrillation.
We have a few viewers that kind of just jumped in. So can we go over this one more time just so we can get this information? It's so important. What indeed are the symptoms to cause you to make an appointment? You know, we talked about, I get a flutter now and again. Is this something that I need to get checked out? If you can just, and both gentlemen, if you can just define the symptoms that if it happened to either one of you, we're going to see someone.
So for a lot of our patients, they present with fatigue or shortness of breath. It's a very non-specific symptom. I walk up a flight of stairs and, I'm feeling short of breath. I can't do the things that I normally could do. I am fatigued. I do things and I'll wake up in the morning, I'll have a cup of coffee, and by 10 o'clock in the morning, I feel like I need to go back to bed. So those are unfortunately very nonspecific and can be related to a lot of different medical causes. But those are some of the more common things that I see for people who have got valvular disease or rhythm disease. And it's unfortunately probably the number one cause or complaint or symptom that I have that people complain of. So that there's that. I'm sorry, Shane, my phone just rang.
No. An easier one is some people actually feel palpitations. They feel their heart going crazy in their chest. It's sustained for some length of time. Some people can even tell that it's irregular, that it's skipping and jumping around. There are other things besides atrial fibrillation that can do that, but such symptoms are very likely to be a sign of atrial fibrillation. Then there's other stuff, like Mo said, that's what we call non-specific, meaning we don't know what's causing it initially. It's something we have to suss out. We have to diagnose and figure out what's going on. But things that are concerning are, just like Mo said, unexplained shortness of breath, chest pain or discomfort, passing out. Those are concerning symptoms, and those are a reason to get checked out, whether it ends up being AFib or something else.
Dr. Shane Rowan, Dr. Moe Lyons, thank you so much for being in attendance for this webinar. A lot of great information, wonderful insight. We had a large live audience. I know they got a lot out of this, and we appreciate here in the middle of the day you guys taking
Dr.
time
Lyons.
out. See, Dr. Lyons has to go.
Hi, Renda.
Dr. Rowan, Dr. Lyons, thank you so much. We appreciate it. And thank you, folks, for attending. Our next webinar is going to be May 26th. It's going to focus on how the quality of sleep can impact the health of your heart. We touched on a little bit of that today. Thanks for watching.
Thank you.